Respected judges and dear colleagues, a very good afternoon to you all. My name is Dr. Bhadari, and today I'm here to speak to you about comparing postoperative endophthalmitis in operating rooms with or without laminar airflow and high efficiency particulate air filters. I have no financial interest to disclose. Now, looking at cataract surgeries, are the most commonly performed surgeries worldwide, with 20 million surgeries performed per year. And postoperative endophthalmitis is a very rare complication with incidence rates ranging from 0.03 to 0.21%. In 1927, Dr. Lidwell et al. Came out with a paper which talked about surgical site infections in post-arthroscopy and post-hip replacement patients, which were attributed to airborne bacteria, after which operating rooms with laminar airflow and HEPA filters have been the standard worldwide. But the question comes to whether the cost-benefit analysis is actually there because of the increased demands of energy, the increased cost of construction, and also increased pollution, which occurs as a result of all the expensive systems that we are using for air handling in operating theaters. Now, in 2020 and afterwards, an interesting series of papers came out on whether phacoemulsification, which is the most commonly performed procedure, generates aerosols or not. And we have conclusive evidence which says that it is not a high aerosol generating procedure, unlike the orthopedic surgeries on which the need for HEPA has been established as of today. So we had a confusion as to whether we needed these high-end systems in ophthalmic ORs, and we turned to our hospital system, which has a total of 17 surgical units with a variety of air handling units, namely Group 1, which is laminar airflow with HEPA filters, Group 2, central air conditioning with HEPA filters, Group 3, central air conditioning without HEPA filters, and Group 4, split air conditioning. So we did a retrospective consecutive case series analysis on these. Looking at the already established literature from our institute on how we could use flash sterilization to drop endophthalmitis rates, and also how we could use intracameral moxifloxacin to significantly reduce postoperative endophthalmitis, we also decided to seek out whether we would need high-end filtration systems in our operating rooms. So as mentioned earlier, we analyzed all the cataract surgeries performed across all our institutes in 2023, which numbered to 450,000 plus. Looking at the split of cases, it was across, it was around 280,000 and more surgeries as MIS-ICS, and over 170,000 surgeries as PHACOs. Now, looking at the post-op endophthalmitis rates from the same and the number of surgeries across all groups were almost similar, ranging from 93,000 in Group 3, which is AC without HEPA, to 128,000 in Group 2, which is AC with HEPA. Now, looking at the endophthalmitis rates, we had a total of 74 patients and 14 who turned culture positive. And the rates in Group 1 through 4 were 0.013, 0.016, 0.017, and 0.019% respectively, with a p-value greater than 0.05, which negated any statistically significant difference between the 4 groups. Also, looking at whether there were any differences between phacoemulsification or SICS as a procedure for the same, we noticed that the numbers are as follows, and the p-values are all above 0.05, which means that there is no statistically significant difference. Also, looking at whether the paying side of the hospital and the charitable side of the hospital would have had different practices or difference in endophthalmitis rates across the operating rooms. Again, the numbers showed us that the p-values all numbered more than 0.05, which clearly shows us that we do not need laminar airflow or high efficiency particulate air filters to work towards safe cataract surgeries and lesser rates of postoperative endophthalmitis in ophthalmic operating rooms. Thank you.
So what is your conclusion for ophthalmic surgery? Is LAF plus HEPA is required or not?
No, sir, it is not required, because the postoperative endophthalmitis.
NABH accreditation?
Yes, sir. With respect to the recent NABH accreditations, ophthalmic operative rooms have been brought under Type 2. So they have been erstwhile mentioned as general OTs, but now they've been put under a special classification, wherein they do not mandate laminar airflow, but they would suggest that all hospitals have laminar airflow and HEPA filters with positive pressure on throughout the day, 24/7, even when working and not working in all the operating rooms.
Till very recently, they were not giving accreditation without
No,
HEPA.
sir, they weren't. I just had a look at the guidelines today morning as well, sir, which is the one that I'm referring to, wherein Type A and Type B are there. Type A is for super specialty surgeries, especially aerosol generating procedures such as hip replacement such from orthopedics. Type B is where our OT falls in right now, which is ophthalmic surgeries, erstwhile called as general OTs, but now a special category. Still, the guidelines are a bit vague on whether we have to use them or not, and this, whatever data we have concluded from our study would go a long way in helping them make a decision, an informed decision for the same.
Yes, you're right. This data is going to help us.
Yes, sir.
Fine. Similarly, more data from different centers need to come.
Definitely, sir, yes.
Fine, so that there can be a collective data,
Yes, sir.
which shows that yes, this and without filtration, it is same thing.
Yes.
Did you encounter any cluster endophthalmitis also?
No, sir. So routinely in our system, we have a concept of infection control meetings which happen at the end of every financial year. So it'll be in the late week of March, wherein we analyze the entire year. So speaking for 2023 and 2024, we didn't have clusters per se, but we've noticed that always the endophthalmitis rates are a bit higher among the summer months, so March, April, and May. We have not noticed any clusters in 2023 in our centers.
This data is from one center.
No, sir. It's from the entire system. So it's a total of 14 centers
14
and 17 surgical units, sir. So surgical units
It's
might be
all
different
collective
between
data.
centers. Everything put together, yes, sir.
Good. No, we need to have more data from more centers, fine, from all over the country, so that these recommendations can be shared with NABH authorities. Fine. Thank you very much. Nice,
Thank you, sir.
nice work.
Thank you.
Nice work. Thank you.